Evening, everybody. Let us start another episode of Surgical Academia. And as it is customary, let me have the introduction of Surgical Academia to the audience, new audience, and Surgical Academia to the speakers as well. So, this is just a video introduction of Surgical Academia. Yeah, I think this is Surgical Academia as was started in 2012. It was involved in lot many live workshops, teaching sessions. They were all being carried out. So I think slowly and slowly, residents from across the state, faculties from across the state, residents, faculties from many parts of the country started joining this platform, and teaching training sessions, they all continued with all live workshops and all. These requests also started coming in from SAR countries and many other parts of the world to get surgeons to get themselves trained in laparoscopic surgery. So this surgical academia became more of a teaching and training platform. So the people were getting trained, and faculties, seniors, they were also cooperating to the highest extent. So after the end of a training, all people were recognized with their contribution that they had made in the period of training. So this became a very collective and cohesive work. Then I switched over to AIIMS Bhubaneswar in 2018 with the same passion of teaching and training. So Advanced Laparoscopic Surgery Training Center was inaugurated in AIIMS Bhubaneswar. Then we had the first PDF course in minimal access surgery, the first of its kind in the Eastern zone, also was inaugurated. Then came the COVID pandemic. So from after COVID pandemic, it was all solo venture. I was doing a weekly webinar myself with all laparoscopic surgery topics, and it continued for 3 months. But then I felt that I should invite my colleagues across the country, and I was very fortunate. Colleagues across the country and as well as from abroad, they all agreed to come into the platform and started sharing their wisdom and experience. And so Surgical Academia is now not only a platform, it's an educational movement. So today in that process, we have an excellent debate arranged on laparoscopic hernia versus open hernia repair. And we have got two eminent and distinguished speakers with us. The first speaker will be obviously laparoscopic repair by Dr. Bhatia, but let me introduce first Professor Desarda Mohan Phulchand, who is a professor of surgery and chief of hernia center at Pune Hospital and Research Center in Pune in Maharashtra in India. In fact, Professor Desarda, his interest is in research and development of different types of external hernias. He is the sole investigator in many clinical studies and has been involved in the study of a new technique, which is tension-free and mesh-free groin hernia repair, that is known in the name of Desarda repair. Desarda repair is now followed in many countries around the world. And in fact, before I knew Dr. Desarda, I just had heard that a Desarda repair is there, but I never had any interest of knowing the technique of it, because for last, I do not remember when the last open hernia surgery I had done. That is somewhere around maybe a decade and a half back. So when I came to AIIMS Bhubaneswar, I came to know that one resident is doing Desarda repair as his thesis. So I was very much interested. In fact, then I got myself in how Desarda repair, how the technique and everything is going on. So Professor Desarda has got many achievements in his name. He has a new technique and he has inscribed his name in the textbook in maybe probably one of the few Indians whose name you'll find in hernia surgery in the textbook. He has revolutionized the basic concept of hernia, and he has got innumerable awards and honors that will run into pages. He has a book in the name of Desarda repair, which was published last year. In fact, my association with Dr. Desarda was not very long ago. I, in fact, had heard his name, but had no opportunity of meeting him because probably Dr. Desarda was not coming to any laparoscopic surgery conference because I had no opportunity of meeting him. Might be he might have come to some conferences. I had not met him till there was a panel discussion under Hernia Society of India where I was in fact invited as a speaker to give my deliberations on laparoscopic repair, where Professor Desarda was talking on open hernia surgery and its benefits, Desarda repair and his technique and all the benefits that the open tissue repair is giving to the world. So in that webinar, in fact, I got introduced to Dr. Desarda, and what I found that he is an excellent human being. In fact, after that, many times I had many interactions with him. It was really so loving, so friendly to talk to him. He was a passionate, very kind human being. In fact, he liked me very much. So in that process, then I once requested him, sir, why not we have a debate? And in that debate, you will also give your viewpoints, and I will choose another diehard laparoscopic surgeon who is very much an expert in laparoscopic hernia repair. And believe me, in this webinar, uh, I being a moderator, I just want to keep myself unbiased. The whole motto of this debate is not to underestimate, not to overestimate any procedure. Just we need to go to the scientific basis of things that's happening around. So we just need to hear both of them. This is Professor Desarda's book of Desarda Repair for Inguinal Hernia. Is a mess-free, tension-free, pure tissue repair based on physiological principle. Apart from this surgical excellence, Professor Desarda has got another extracurricular achievement in the form of his has got learned yoga, and he has applied that yoga into this physiology of hernia repair as well. So then my search was to find a person who can have a very good debate with Professor Desarda, and in fact my automatic choice was Dr. Parveen Bhatia, whom I know for last more than a decade. He's a senior consultant laparoscopic bariatric and robotic surgeon in Institute of Minimal Access and Metabolic Bariatric Surgery in Sar Gangaram Hospital, New Delhi. He has his own Bhatia Global Hospital as well. Dr. Bhatia, after his initial years of training in Mansi and RML, had got himself trained in many leading centers in the world in minimal access surgery, and he is an acclaimed faculty in many national and international conferences, has authored 3 books in minimal access surgery, and one of them is on laparoscopic hernia repair. Apart from being a good surgeon, Dr. Bhatia has got some outstanding qualities. He is an excellent motivational speaker. Dr. Bhatia can motivate any audience to any point. He is such a motivational speaker. And apart from this, he loves adventure sport too, and he loves skydiving. It is something which is unusual with surgeons, but he is a very avid skydiver. He is always a motivated, well accessible friend. And my association with Dr. Bhatia is more than a decade, and it became much closer when Dr. Bhatia and myself, both of us were governing council member in Association of Surgeons of India from 2013 to 2015. Beyond that, we had innumerable exchanges in many conferences. So it was a pleasure sharing the podium with Dr. Bhatia many times in many conferences. Unlike, unfortunately, I had no option of sharing with Dr. Desarda, apart from only one occasion from where actually he became a very good friend of mine. So Dr. Bhatia has got many honors and accolades in his name. So that also runs into pages. I may not elaborate them. He's a fantastic family man. So that shows and proves that. So my best wishes to Madam Bhatia as well. So this is the thesis that I had done in 1994. That was again a Prolene mesh repair as a positive remedial measure in repair of recurrent inguinal hernias. So in fact, this webinar reminded me of my thesis. I remember in 1994 when I was doing this recurrent inguinal hernias with a Prolene mesh, faculties and residents in the department, they were raising their eyebrows. Everybody was telling, Manas, why are you putting unnecessary foreign body to a hernia? A simple tissue repair is good enough. Why are you unnecessarily doing that? Believe me, after down the line, after 5-7 years, it became a norm that no mess, no hernia. So whether it is open surgery, whether it is laparoscopic surgery, no mess, no hernia. But at one point, I'm again thinking back, are we again, it's a pendulum effect, are we again swinging back to square one? So that's why I've chosen Professor Desarda himself to prove that is mess a myth? Is mess not required for a hernia surgery? Probably Dr. Desarda will always say that mess is absolutely not required, and probably he is the right person to prove that also. And that he will be doing after Dr. Bhatia explains why at all we have switched over from open surgery to laparoscopic hernia surgery. Probably laparoscopy hernia surgery has cut the world in stone, whether it is TAPP, what is TEP, whether E-tape. I mean, everybody is now after laparoscopic hernia repair. And probably this has convinced surgeons across the globe that there is no second thought that laparoscopy is far, far better than open surgery. But still, at the same time, as I had told earlier, that I being a moderator, have, even though I am a die-hard laparoscopic hernia surgeon, but I have no bias at all whether to open surgery, not to laparoscopic surgery. Let us value and weigh both of them equally and hear both of them, how they value and prove that one is superior to the other. So in this series, the next week, same time, we'll be meeting with another fantastic session that will be on Whipple's operation. I think anything that we need to know on Whipple's, Professor Sikande from Tata Memorial Hospital and Professor Marcus Buechler, who was in fact the man who had devised the technique of modified Heidelberg technique, initial Heidelberg, and when Dr. Sikande and Dr. Buechler, both of them combined, they had a fantastic publication that is modified Heidelberg technique for pancreatic ozonostomy. I think it's a big opportunity to listen to both of them, and it starts right from the patient preparation till vein resection and beyond, what a surgeon need to know on Whipple's. So that's coming up next week, same time. All of you are welcome to the next week, same time, this webinar on pancreas. So without wasting much time, let me have the opportunity to call on Dr. Bhatia to present his laparoscopic repair, why he feels that laparoscopy is the buzzword and laparoscopy is the only solution for hernia, not the open surgery. So Dr. Bhatia, the screen and air, everything is yours. So please share your thoughts.
Thank you very much. Thank you, Dr. Manas, and thank you, Dr. Desarda. I honestly appreciate the invite on Tuesday evening. You are doing an excellent work of educating, connecting, and a get-together on such kind of occasions. And then work is being converted into play also. That all of us are sharing our thoughts and we are enjoying also. And today I am going to present on laparoscopic hernia repair. To start with, I would put it this way. So I would start again that it is not the wound that teaches, but the healing. And believe me, I am not going to fight with the professors today. I know Dr. Professor Desarda and Dr. Professor Manash Sahoo, they are professors and I'm a doctor. And I am not going to have any fight whether one should carry on doing the open repair or laparoscopic repair. I think most important is that we should have a discussion in which there is a light rather than a heat. And the essence of this kind of discussion or debate is that are we discussing about the open sutured tissue repair versus laparoscopic mesh inguinal hernia repair. And I bring greetings from Institute of Minimal Access Metabolic and Bariatric Surgery and Institute of Robotic Surgery, Sir Gangaram Hospital, as well as from Bhatia Global Hospital and Endosurgery Institute. If we consider whole of the gamut of hernia, I would say that there is no precise data which is available. And in US itself, for example, you can see that 500,000 to 750,000 repairs are done annually. And if we see the global burden of hernia disease, it is 18.9 million global incidents, and the male and female ratio is of the order of 19:1. And if we have to consider the outcomes of groin hernia repair, then in the past, all of us have been bothered about the recurrences. And as I remember that when I did my thesis way back in 1988, then I did it on shoulders repair under local anesthesia. And we used to send the patient the same very evening or the next day and then follow them up for years and years, and found out that yes, the shoulders repair of double breasting was doing an excellent job as compared to bassini repair. But I would always say that gold standards are changing. When I became the senior resident, then the Lichtenstein repair was started, and all of us started believing the data from the literature that mesh definitely causes and leads on to reduction of 50 to 75% chances of recurrence if the mesh is placed, and the tissue repair ultimately was taken over by Lichtenstein repair. And when I finished my senior residency, then we started our laparoscopic career way back in 92, 93, when I had gone to Barry McKernan, who is the pioneer of TEP, and Chris Royston, who is the pioneer of TAPP. And then we started our laparoscopic career. And from that time onwards, we have never looked back. But today, when we see the outcomes of inguinal hernia repair, definitely the recurrence rates have come down drastically. I will be discussing about the recurrence rates later on, but they have come down drastically from the bassini to shoulders to Lichtenstein to TEP to TAPP. And now we are discussing about the expedient recovery. Pain is the concern in the post-op period, and the quality of life has to be seen. And we know that the recurrence rate have been ranging from 0.5 to 15%, and same way, pain is also ranging from 0.7 to 75%. And I am thankful to Dr. Desarda that I could dig out good number of his articles, and in this Saudi Journal of Gastroenterology, he had written an article about a dream or a reality, no mesh inguinal hernia repair with continuous absorbable sutures. Previously, he was using a non-absorbable suture, but now he had reported a continuous absorbable suture. But in this, he had beautifully mentioned that failure rates for general surgeons without expertise in hernia surgery, who perform most hernia repairs in secondary or tertiary level general hospitals, remain significantly higher, up to 10% for primary hernias and 5 to 35% for recurrent hernias. And again, going into details, we could find out the articles on elective and emergency surgeries. So the outline of my presentation would be that do we think in today's era that mesh is a must? To my mind, mesh is a must, whether we are going in for open repair or laparoscopic repair. Mesh is a must because the tissues are already having maybe collagen deficiency, and they are not as protective for recurrence. And again, in the mind of the surgeon, in the mind of the patient, all of us are bothered about recurrence rates. I will be discussing about the recurrence rates, that how the base knees repair had a recurrence rate as high as 15 or 17% but now we are heading towards duck recurrence of TEP and TAPP. And if Dr. Desarda or someone who is a ardent open hernia man, if he tells me that his patients do not have any neuropraxia or neuralgia because of the cutting of the ilioinguinal nerve, or even neuropraxia because of the irritation of these nerves, I think we are not believing the truth. And again, when we were doing the open hernia repair, as I mentioned in my thesis days, then we used to see the recovery of the patient, and it used to take around 3 weeks for complete recovery. We used to tell the patient that you don't have to climb the stairs, you don't have to lift up the weight, and because it is a tissue repair, the chances of recurrence are high, and the return to work was also not as good as in laparoscopic era. Regarding the cost, I would say that there are surgeons who are having excusitis, that they feel that they are not going to adopt to laparoscopic hernia repair because of the cost reason. But according to us, if we have mentioned that mesh is a must, whether we are doing by open method or by laparoscopic method, so the cost of the mesh remains the same. And we have seen in last 3 or 4 decades that laparoscopic cholecystectomy has become the gold standard. Why? There was no randomized controlled trials were done for laparoscopic cholecystectomy, but still it has become the gold standard. Why? Because of the advantage, minimal access advantage to the patient. And this kind of equipment is available to various surgeons, whether in rural India or rural or urban areas. So if the equipment is available, if the mesh is available, only thing is that yes, the patient can afford the cost of the tacker or a fixating device or not. One can always learn the suturing and ultimately offer the best to the patient. And most of us should be bothered about quality of life, whether we will be able to help the patient in such a manner that he will be able to serve the his employment better, that from day 1 or day 2 or day 7 or not, or he will have to take the rest for 7 days. Many times, many surgeons, especially open surgeons, will always harp on that TEP and TAPP has a long learning curve. I don't deny that, but only thing is that if we know our anatomy well, if we have been proctored by the surgeons who are doing good numbers of laparoscopic hernia repair, then if one is able to master the hernia anatomy from within by taking care of critical view of myopectineal orifice, we are able to do the justification. Thinking is that when we do the laparoscopic hernia repair, the most important aspect is the anatomy is more or less similar in all these situations. It is not varied. And if one is able to find out the structures of the myopectineal orifice, the inferior epigastric vessels, iliac vessels, vas and testicular vessels, and so on and so forth, so they are having more or less constant alignment. And if one is able to practice, repractice, practice and practice and practice, then one is able to master the laparoscopic hernia repair. I would always ask my open surgeons that whether they are comfortable in having the penile edema or the scrotal edema if they do bilateral open hernia repair. One. And second thing is that, for example, if the patient has presented with one-sided hernia and there are chances of 28% of contralateral hernia, so are they doing justice to the patient that after few months the patient comes again for the contralateral hernia repair? So if we do TAPP, we are able to diagnose the bilateral hernia, and then we can place in mesh on both the sides, and that's it. And it is done only with 3 ports, not with 2 long incisions on either side of the midline. And then I would ask our opponent that why? What is the cause of recurrence after tissue repair? And what is the cause of recurrence? We have been fortunate or unfortunate, I would put it this way, to get such kind of patients who has had 7, 8, 9 times recurrences after Basini, Scholdes, Lichtenstein, and so on and so forth. Even plastic surgery has been done, myocutaneous flap has been rotated, and still the patient has the recurrence. Is it because of the patient factor, or is it because of the hernia, the surgeon factor? So if such kind of recurrent hernias are there, if it is done by Desarda technique or by Basini or by Scholdes method by tissue repair, are we confident that we have given the best to the patient, or is it going to lead on to another recurrence or not? So that is a questionable. Third thing is that missed hernias. Initially, when we were doing Scholdes repair, for example, there will be some situations in which we would miss either the femoral hernia or obturator hernia. But when we are doing by laparoscopic method, whether we are doing by TAPP or by TEP, we are repairing direct, indirect, femoral, obturator on one side, and same way direct, indirect, femoral and obturator hernia on the contralateral side also. And in this, all of us have learned that the males have predominantly indirect hernia, but femoral hernias, for example, they are more common in female patients. And if we do by open method, the chances are that we will be missing lot of such kind of patients who have been coming for the open hernia repair. Again, not going into the details of the anatomy, but Jorge Dice had beautifully written a publication on critical view of myopectineal orifice. And my viewpoint is that one has to unlearn, learn, and relearn the anatomy. Then only we will be able to justify. And it is not difficult to understand. Only thing is that once we go into details, God lies in details, devil also lies in details. Once we go into the details of these 9 steps of critical view of myopectineal orifice, then one is able to understand the anatomy and the dissection. For example, once we go in, whether we by TAPP or by TEP, first and the important landmark is the White House or the lighthouse, and pubic bone, pubic ramus. And then we start moving from midline to lateral, and as one has to make a space of around 2 centimeters behind in the cave of radius, so that we are able to place in the inferior margin of the mesh comfortably, because it is the medial most recurrence even after laparoscopy or even after open surgery that is commonest. So one has to make sure that we dissect between the bladder and the pubic ramus by 2 centimeters to leave the mesh. And as we start moving laterally, then one has to not to miss the femoral hernia and not to miss the location of the obturator hernia. And as we go laterally, this is the vas deferens and the testicular vessels, which form a triangle of doom. But again and again, we should not leave any peritoneum going into the indirect defect. If we leave a leaf of the peritoneum, then the chances of recurrence will be high. And we have to make a marsupial laterally, not go into the closed area, and leave a mesh of 15 by 12 centimeters each if, for example, if we are doing a bilateral hernia repair, then the chances of recurrence are reduced to minimum. Just a small video clipping that we are graduating. We started with Scholdes. We had learnt Basinis in our postgraduate days, then Scholdes, then Lichtenstein, then TAPP and TEP, and now we are doing ETAP for bilateral inguinal hernia. Means that we are updating ourselves. There is no point of going on a bullock cart today when the aeroplanes and jet and everything is available. If we are not updated, we are outdated. We are always thinking that if we can deliver the best to the patient by having an enhanced view of the anatomy, then we will be able to justify, and we are progressing towards the zero recurrence or the duck recurrence. In this situation, we always say when we do the dissection with the harmonic that follow the white. We have seen the pubic ramus, pubic bone, the white house, the lighthouse, and as we start moving laterally, then we are able to see the peritoneum. And can you appreciate, this is the direct defect and this is the pseudo sac which is being taken away. And if we are using the energy source judiciously, then the chances of any neuropraxia or complications are reduced to minimum. This is the direct effect, and one has to go in alongside the white glistening, follow the white single cell thick peritoneum so that we do not miss the vas deferens, again white, or the testicular vessels, and the inferior margin of the mesh is lying so comfortably that it is not getting rolled in or rolled out. If, for example, I would never ever say that the laparoscopic repair should always be done. Why? Because there are no recurrence. No, it is wrong. It is again, surgeon is the most important prognostic factor. Surgeon has to learn it well. Surgeon has to respect the tissues. Surgeon has to respect the planes. Then only the chances of recurrence will be reduced to duck. And again, small point is that when we are placing in a mesh, then make sure that the lipoma is also taken care of. If the lipoma is going into the defect, the chances of recurrence will be higher. And inferior margin of the mesh should be fixed in such a manner that it is not getting rolled in or rolled up, and it is going laterally also, and then mesh is splayed over or under. What I mean to say, there are surgeons who do it as a carpet, or there are people who will lay it open onto the roof and then make it a point that it is covering the direct, indirect, femoral, obturator by at least 4 centimeters. And when we are doing the bilateral repair, the overlap has to be taken care of so that we do not have any medial recurrences. And this is when we deflate also the extraperitoneum, we are able to see that the mesh has been comfortably placed, and then extraperitoneum is deflated and re-inflated so that we can see that the mesh is lying comfortably in the desired position. Again, I would not go into the technical details of TAPP, but the point is that one has to stay close to the peritoneum. Peritoneum is single cell thick layer, and one should not go beyond into the fascia transversalis. If we are dissecting close to the peritoneum, pre-peritoneal area, and then we are placing in a mesh, then the chances of recurrence are reduced to minimum. Similarly, these kind of situations, once we go in with the laparoscope, once we see in TAPP that bilateral defects are there, then one can place in two meshes, and one is able to do it. Recently, in last week only, we had this patient in which bilateral hernia was there in a female patient, which is quite uncommon, but one could do the TAPP, and once we dissect and fat belongs to the anterior abdominal wall, then we take care of the round ligament, we cut it onto both the sides and then place in a mesh. Again and again, our emphasis is that the God has created the planes for us, the surgeons. We have to identify the planes. We have to remain close to the peritoneum. We should not go into the two lamina of fascia transversalis. We should remain extraperitoneal, we should remain pre-peritoneal, and then develop the space and then place in a mesh so that the chances of recurrence are reduced to duck. And we should definitely mobilize in such a way that the mesh of the size of 15 by 12, we are able to place it comfortably. So thinking is that we should not miss the femoral hernia, we should not miss the obturator hernia. And according to us, eyes don't see when the mind is blind. Means if we do not know that the obturator hernia can be present, then the chances of missing are definitely higher. The many societies guidelines have come, and I would definitely urge my younger colleagues to go into this paper on current concepts of inguinal hernia repair, in which they have taken the representatives from all the different world's hernia societies, and then they have found out that the chances of recurrence after primary repair is of the order of 11%, and 11% of the patients can have the chronic pain. So just multiply these 11% patients who have been done by open or laparoscopic method. If 11% of those 500,000 patients who have been doing annually in US itself, so number goes very high. And 1 to 3% of these patients have severe chronic pain because. So our thinking is that when we are doing the season, whether it is an emergency surgery or whether it is an elective surgery, then one has to make sure that, for example, if it is a bilateral hernia, laparoscopic surgery is the answer. If it is a recurrent hernia, laparoscopic surgery is the answer. If, for example, we are doing primary unilateral hernia, yes, depending on the experience, one can go in for laparoscopy or by open method. But if, for example, if we are having an emergency situation, for example, there is an infected case, or it is an incarcerated hernia, or strangulated hernia, or large scrotal hernia, then there is a place of open repair. I would never ever say that I am an open hernia man or a laparoscopic hernia man. I am a man in which I am able to give the best to the patient. But in these situations also, in emergency situations also, I would definitely love to put in the scope and find out from myself that whether we are able to reduce the hernia and then do the, for example, it is not strangulated, then I will carry on with laparoscopic method. But if the strangulation is there, if the resection anastomosis has to be done, then open surgery has to be done and tissue repair has to be done. And again, if, for example, there is a recurrence after the open previous repair, then definitely laparoscopy is the answer. But if the recurrence has occurred after laparoscopic repair, then one has to change the route and go in for open repair. And Lichtenstein is the choice, not the tissue repair, which is the choice. Because in such kind of situations, also one encounters such patients in which, for example, first the tissue repair was done, then mesh repair was done, then even then hernia was there, and again the hernia recurrence has occurred after laparoscopy. So for that we always offer the TAPP. And the advantage of diagnostic laparoscopy in emergency situation is, for example, this patient had presented with obstructed hernia, inguinal hernia on the left side. But when we did go in with the diagnostic laparoscopy, we could see the hernia on the contralateral side also. And then because there was no strangulation, no incarceration, and we could do the justice on both the sides with just 3 small punctures of 10 millimeter and 2 5 millimeter. So advantage is definitely there in laparoscopy. Recovery is faster. Patient is able to resume his or her work later on. I would never ever say that yes, gold standard is TEP or TAPP. There are situations in which, for example, now you see the TEP has been done by some surgeon and he has missed this dissection. That means medial most recurrence is there on both the sides. Can you imagine that? And we did by TAPP method, we did the repair. And in this kind of situation, we have to do the dissection between the peritoneum and the mesh, or between the mesh and the tissues, and then we are able to place 2 meshes on both the sides. We don't have to remove the previous mesh. Means that even if some challenge is there, and these kind of situations are there, I would say depending on the expertise, depending on the experience. If, for example, this patient has had open hernia repair, and then bilateral TEP has been done, and then the recurrence is there, that means we have to go in for TAPP, because even if we go back with laparoscopy, with open repair, then we will not find the same kind of tissues which have been rogered. Rogered is the right word because of the fibrosis. So we will not be able to find the planes, and then the patient will carry on having recurrent hernias. So thinking is that one should be ready to do and take such kind of challenging situations in which we are able to offer the best. Similarly, you can appreciate that this is again the medial most recurrence after placement of the mesh, and again we do the diagnostic laparoscopy and do it. So thinking is that again, just relying on the recurrence rate. This is a beautiful publication of Dr. Anil Sharma in Annals of Laparoscopy and Endoscopic Surgery, and it is seen that after tissue repair, the recurrence rates are of the order of 30%, 10 to 30%. And if we still ignore that my patients are not having recurrences, or the surgeon is lying, or the patients are going to some other surgeon. And the shoulders repair has a recurrence rate of 0.2 to 4.8%. Lichtenstein definitely reduced the recurrences from 0.5 to 2.4, but the TEP and TAPP, we are nearly, I would not say that we have reached the target of duck recurrence, but definitely the recurrence is being reduced. So one has to take care of these surgical risk factors. One should definitely make it an attempt that we are able to justify our presence. And there are surgeons, I know that my opponent will say that in laparoscopic surgery, you may take more time. In open surgery, I do not take time and I do the surgery very fast. No, our thinking is that once you have done the surgery again and again, and you are operating with compass and not clock in mind, then the chances of recurrence are reduced to minimum. Ultimately, I always ask the patient whether you want a fast surgery or you want a safe surgery. Patient always says, sir, I believe on you, I have trust on you, I want a safe surgery. Same way, the centers in which the lot of hernia surgeries are done, for example, in Gangaram Hospital or in Bhatia Global Hospital, we are doing laparoscopic hernia repair day in and day out. The chances of reoperation are definitely reduced. And it all depends on the surgeon volume. Again and again, I am emphasizing that the surgeon is the most important prognostic factor. So we should always be careful, and it is all about finding the calm in the chaos. So much of chaos has been there in hernia surgery for last so many years or decades. But if we are able to offer the best to the patient, with zero recurrence or near zero recurrence, we will do the justice to the patient. Thank you very much. But in a nutshell, I would say that in emergency situations, yes, there will be a time of low threshold of CT scan, low, and doing the diagnostic laparoscopy and or open tissue repair. But in otherwise, if, for example, there has been some infection, definitely one should not place in a synthetic mesh. But if there is a strangulation, one should not place in a mesh. Otherwise, mesh is a must. Thank you very much. Thanks a lot. Over to Dr. Manash Sahoo and Dr. Desarda now.
Thank you very much, Dr. Bhatia, for those excellent disposition on laparoscopic advantage of doing hernia repair. But I had committed from the beginning that being a moderator, I just want to remain unbiased. So, in fact, I told that we are just debating the scientific facts. We are not underestimating, neither we are overestimating a procedure. As somebody had rightly told that in 21st century, illiterates are not those who are not able to read and write, those who do not want to unlearn, learn and relearn. So we cannot...
Elvin Toffler.
Elvin Toffler. And in fact, we cannot stop waves coming in the sea. We just need to swim with it. So science is science. Science will always go on progressing. We cannot say that this is the end word for a procedure. Everything will keep on changing. So as Dr. Bhatia clearly told that one thing, surgeon is the most important critical variable in a procedure, be it hernia surgery, be it any surgery. So if you are not doing a good volume of cases, so surely your competence level goes down. So if a surgeon doing laparoscopic surgery tells that it takes longer time, there is no more chances of recurrence, there is some problem somewhere in the technique. So quite often I had seen initially people when they start doing laparoscopic hernia repair, they do not paralyze well. They just put a small mess, just somehow or other they come out of it. And then after 2 months or 3 months, somebody comes back with a recurrence. Then they'll no, laparoscopy is a bad procedure. It's nothing to do with the procedure. It's all the surgeon is the most important critical variable which actually changes the entire spectrum, whether the result of the procedure is going in a safer way, whether the result is particularly is delivered to the patient as he requires it. So that in fact surgeon actually decides the whole event and whole factor. So we have heard everything about laparoscopic advantage, and at the same time we also heard that open surgery is not a no. There are situations where open surgery has to be done, and in fact open surgery for a resident, when he starts learning, he has to start from open surgery first, as in any other laparoscopy procedure as well. But unfortunately, the scenario is also changing very fast. If I ask my resident, how many open cholecystectomy you have seen, you will tell I have never seen one. Similarly, if you ask him how many open hernias, he will tell, he'll surely say that I have also seen very less. But fortunately, there was a resident in our department who was doing a thesis on Desarda repair. So that's what I was telling, that when I switched over to EMS, I only heard about Desarda repair, but I had never given my thought into it. But when I found a resident is doing here Desarda repair, so I just was curious. I mean, why at this point of time, when everybody is switching over to laparoscopic repair, somebody is doing Desarda repair? So it was a good fortune for me to come in contact with Dr. Desarda in that Hernia Society of India meeting, where he was giving all his thoughts on the open surgery and I was giving all thoughts on laparoscopic hernia repair. So we had a fantastic interaction, and following that, Desarda sir became a very good friend of mine, as a fantastic human and humble human being who really appreciated every thinking of mine. Then he started explaining me, and then I thought it is fantastic to have a good debate. So now it's time for you, Desarda sir, just to share your thoughts, why you think still in the era of laparoscopic surgery, a no tension-free, mess-free repair still stands. How the tissue repair can give the best result. So may I now invite Dr. Desarda to please share his thoughts. Over to you, sir.
Let me first of all wish you all participants and Dr. Bhatia and of course yourself a very, very happy and prosperous and peaceful new year for you all. I actually met Dr. Bhatia long back when he came to Pune Hospital to deliver a lecture talking about biological mesh for ventral hernias. I hope he remembers that. At that time, I asked him a question, whether would he apply this to all ventral hernias or midline abdominal wall hernias, for small and medium sized hernias also. Then he clearly said, no, for small and medium sized hernias, he will do a anatomical repair. So in this lecture, I am going to give answers to all the questions and counter many statements made by Dr. Bhatia. First of all, let me tell you all that I am not against laparoscopic surgery at all. In fact, I have said, even in Germany, where 500 laparoscopic surgeons were sitting in front of me, that I am not against laparoscopic surgery because, and I said that it is a boon to the mankind. But I am deadly against doing laparoscopic hernia repair because the thing which is seen just below the skin, why you want to go into inside the abdomen? Anyway, let us start with misconceptions present in your mind for more than 100 years. You all feel that transversalis fascia is present in posterior wall of the inguinal canal and its strength protects from the recurrences. This is not true. First of all, you understand this. The posterior wall is formed by the aponeurotic extensions from the transversus abdominis muscle. Transversalis fascia lays behind this and is papery thin without any strength, Aponeurotic extensions give physiologically dynamic protection as against the static protection given by mesh in hernia repair. Inguinal hernia formation can take place if these aponeurotic extensions are absent or deficient, and this is genetically determined. See, this is the picture. This one is the picture of a normal man where floor is fully protected by aponeurotic extensions, so there is no hernia. Whereas in this picture on the right side, half of the floor is protected by remaining half is protected, but remaining half shows defect in this cover. So hernia took place through this defect. So which is the ideal operation technique? Forget about laparoscopy, open repair, mesh repair, bassinet repair, anything. Obviously that which replaces the defective or absent aponeurotic extensions in the posterior wall with a new aponeurotic structure. And that is exactly what is done in our operation technique. A revolution in hernia surgery. An undetached strip of external oblique is transferred to become a new posterior wall of the spinal canal, a muscle transfer technique. This new wall is physiologically dynamic and strong, just as is seen in many normal men without hernia. Why bassini shoulder have failed? Dr. Bhatia had already told that there is up to 30% recurrence rates, etc. But of course said that shoulder is much better. I'll tell you why these have failed. We have modified the operation the way it suits to us. In fact, Bassini himself in his series had given just 4% recurrence rate and not 30%, remember. We have omitted the first important step of excising weak inguinal floor because of risk involved in this complicated and complex dissection. This entire weak floor is to be excised. That is the first step. Muscles are displaced from its original place, so it tries to go back to its original place, like this. Muscles are pulled down to suture to inguinal ligaments, so they are under tension even at rest. This tension increases manifold during action. This tension increases further due to shrinkage of fibrous tissue in later life. This results in more pain and more recurrences in these tension repairs. Liechtenstein mesh repair. Liechtenstein puts a mesh, a mechanical barrier. Nobody uses classical Liechtenstein mesh for repairs. A bi-tailed mesh with knitted borders was used by him. It means nowadays everybody is doing different Liechtenstein, not real Liechtenstein. Now mesh is cut to suit surgeon's choice to reduce the cost. Loose or tight suturing of mesh can't be standardized. Size of the mesh also can't be standardized. Quality of mesh fabric is also not standardized. Why low quality mesh for poor and high quality mesh for rich? Mesh is a foreign body, a simple piece of synthetic cloth, naturally associated with all foreign body complications like pain, recurrence, infection, etc. Why not laparoscopic repair? I'm sorry, Dr. Bhatia. All complications of mesh are present in laparoscopic repairs also. In fact, these complications carry high risk because mesh is stitched inside the abdomen, periperitoneum. Additional complications are internal oozing, risk of general anesthesia, nerve damage, trauma to viscera, trocar hernia, and of course, there are so many other complications. You can imagine what would happen to vas and testicular vessels due to mesh fibrosis because mesh is directly sprayed on these vessels. See, these are the vessels over here. Vas and testicular vessels, mesh is directly sprayed on this. So you can imagine what would happen because of fibrosis over there. Thus, you know that mesh is not 100% safe to the body for its routine use in all the cases. Lap repairs carry higher risk and requires extreme skills and may result in more serious complications. Many patients' life worldwide might be getting affected by unscrupulous use of endoscopes by inadequately trained surgeons. I agree with Dr. Bhatia. In his hands, everything is fine. Imagine the fate of millions of patients operated in remote places by many surgeons with low quality mesh without any standards. Surgical fraternity thrives for 100% safety and cure without complications in every surgery. Then how we have accepted mesh repairs in spite of its morbidity and complications? It's because good pure tissue repair was not available to common general surgeons. It's because mesh repair is a simple operation, and also because of the perfect marketing at all levels and by all means by the companies. Product costing few hundred rupees is being sold at exorbitant price, making huge profits. Therefore, companies will market this product by all means. What is their marketing magic? It's very interesting. Publish repeatedly similar articles through various doctors claiming mesh repair is the best. Make leading doctors to repeatedly present in seminars and conferences how mesh repair is the best. Start CME conferences and make it compulsory to attend to postgraduate students and then hammer on to their mind, same thing again, how mesh repair is the best. Come out with the new products of mesh and again send leading doctors to various seminars to show how mesh repair is the best. Advantage of faith posed by trainee doctors and students in their teachers is exploited. Repeated presentations are made in the conferences, repeated publications are made in the journals, and the song about mesh goes on and on till junior and budding surgeons' mind gets preconditioned to such an extent that they stop thinking beyond mesh for repairs. Who is the loser? The deadliest loser is your own patient. Many patients operated with mesh, open or laparoscopic repair, suffer from morbidity and complications. I think Dr. Bhatia must be having data about this also. Some patients' life gets ruined. Who is responsible for this? But still companies with our help are busy in marketing their product like a soap or hair shampoo. Every time coming out with a new variant of the same synthetic cloth like mesh, then mesh and plug, then PHS, then heavyweight, then lightweight, then small bore, then large bore, etc., etc. And who is the winner? And the winner is mesh manufacturing company that silently pocket millions of dollars profit every year from all over the world. And what about doctors who are catalytic agents and with whose help companies are making huge profits get? Nothing. Our prestigious organizations have all given our platform to them and made them financially giant. But still we doctors have to bargain with them about selling stalls or getting advertisements or sponsorships. So on this background, do we need to change from mesh repair to this repair now? My answer is yes. Because it is simple and safe to do operation even in the hands of junior surgeons with good results. See, each and every word in this lecture is very important. Does not use foreign body or weak muscle and fascia for repair. Early ambulation without much pain. Patient goes back to home in a day and back to his work within a week. You repair hernia with continuous absolute sutures, a thing never imagined. I'm thankful to Dr. Bhatia for going through my Saudi Arabia journal article published over there. It is physiological, tension-free and mesh-free with the lowest rate of complications. It can be done on outdoor basis under local anesthesia and with fast recovery. Then why do you want to give general anesthesia for doing laparoscopic surgery? It removes disadvantages of both foreign body as seen with mesh and tension as seen with other pure tissue repairs. Remember, more than 200 presentations or publications and many RCTs are conducted on this repair. Results are similar or superior. Many textbooks like Love and Belly, Schwartz, etc. have mentioned this technique. Let us see how protection is given. We have postulated that physiologically dynamic and elastic posterior wall gives better protection than a simple rigid anatomical wall. Mesh repair gives anatomical rigid wall, so it is at rest relaxed, but remains relaxed during action also whenever there is blow. Whereas in my repair, it gives elastic and physiological wall, which is at rest relaxed, but springs into action whenever there is a blow. Springs into a shielding protection action, physiologically dynamic protection. Protection in later period. In mesh repair, rigid wall moves en masse like this, pressure on the suture line. So you will find always recurrence on the suture line. Whereas in my repair, elastic wall absorbs blows and pressure is distributed equally. You can again see this mesh repair en masse movement, whereas in my repair it is elastic wall. protection in mesh repair is 0 on day 1. I hope Dr. Bhatia agrees with this. And slowly and gradually goes on increasing over years together. Whereas in my repair, the protection is 100% on day 1 itself. Status today. We are the first to put before the world that inguinal hernia must be repaired on physiological principle. This is very important and you should accept all those things. We are the first to scrap century-old theory of transversal asphyxia and publish new theory of apneurotic extensions. I hope you should, you all should go through my new theories, etc., written in the books. We are the first to give you a very simple hernia repair that does not use foreign body, complex dissection, or costly equipments. We are the first to use continuous all absorbable sutures inside. We are the first to give you a very low recurrence and complication rates, even in the hands of junior surgeons. That is very important. Because everywhere there cannot be expert surgeons available. Wikipedia was the first to describe it in a separate section as tension-free pure tissue repair. Here now I am presenting a data of 66 RCTs or comparative studies and 15 million studies published from 2001 onwards was extracted. Total data of 31,374 patients was collected and analyzed. What it showed? Recurrence was just 0.8% in Desarda, 6% in mesh and others. Mesh and others means open mesh or TAPP-TP. Chronic groin pain 1% in Desarda and 23% in mesh and others. Complications 4 to 5% in Desarda and 19% in mesh and others. Free mobility was just in 33 hours in Desarda, whereas it took 76 hours for mesh and others. And return to normal work was just 9 days in Desarda and 16 days for others. The cost was $14 for Desarda and $68 from mesh and others. There is no bias in this because this is a global data. Operations done by different surgeons, 200 surgeons. So conclusions are, both Desarda and Liechtenstein technique provided satisfactory treatment for a primary inguinal hernia. But the recurrence and complication rates were significantly less in Desarda repair with advantage of no foreign body and reduced cost. Many large and small RCTs, comparative studies and individual studies with follow-up study of 1 to 10 years have equivocally endorsed that Desarda technique is much superior to other repairs in terms of recurrences and complications. There is hardly any incidence of chronic groin pain and other complications specifically seen with mesh implants. Therefore, Desarda repair has a potential to become the gold standard for the inguinal hernia repairs. Last, warning. Ethicon. Listen this very carefully. Ethicon, Boston Scientific Corp and CR Bard are among 7 companies facing more than 70,000 mesh injury lawsuits in federal court and thousands of additional cases in state courts of USA. Here, companies are playing safe by using doctor's card in the court litigations. Ethicon's lawyer said the product was thoroughly certified by the doctors and the doctors considered the mesh use to be the gold standard for treatment. Therefore, I suggest that every surgeon now should take an informed consent in writing from the patient to avoid the court litigations in future following mesh complications after mesh repair because you are implanting a foreign material inside the body of the patient. Thank you very much. Now we will watch our step-by-step operation technique.
Exposed as usual. Here one point is important, there is always a filmy layer covering the external oblique aponeurosis.
Sahoo, can you hear?
Try to preserve this filmy layer on the
Yes, we can hear it. We can hear it.
Okay, fine.
But it's not a must. Even if you, while dissecting, even if you take out this filmy layer above that, doesn't matter. But try to preserve that filmy layer because it keeps these fibers of the aponeurosis close together. It doesn't allow separation. Then a regular incision is taken in this knife.
This is live operation demonstration given in Germany.
Or the weakness of any part of this external oblique aponeurosis. I can find this external oblique aponeurosis absolutely okay over here. So I am just taking an incision on the top of the swelling. Okay. figure. Now this should be continued to break open the ring over there. And go laterally, see this is the nerve is there, you have to protect the nerve. Here. Now I'm just going laterally up to the inferior epigastric vessels. You can beautifully see those inferior epigastric vessels. Can you see? I am now taking a suture from the transversus abdominis aponeurotic arch or the muscle arch to invert this sac inside this articulosis. We approximate this upper leaf and suture it to the inguinal ligament from pubic tubercle to the internal ring. I just show how the first stitch is taken. See, this is pubic tubercle. Can you see that? It's very clearly depicted. This is pubic tubercle. Though I have written in my operation notes that you should start from the pubic tubercle, you should never take stitch through the pubic tubercle. Rather, you should take a first stitch through the lacunar ligament. Or if you can't identify the lacunar ligament, just take a medialmost part of the inguinal ligament. See this? And always test the strength like this, pulling it. See, I am pulling it out to see the strength of that. Now here again, see always there is a cover of the fat in this medialmost part of the upper leaf. Some doctors, sometimes by mistake, they suture the fat and they don't suture the aponeurotic part. So you have to be very careful over here because I found that in one surgeon from Korea, he is doing these operations for last 10 years and he had one recurrence. Then I just tried to evaluate why there was a recurrence and then this was the reason. Sister, can you give me a little smaller needle holder? Now see, upper leaf is sutured to the inguinal ligament. I always say that stitch stays over there. See this? Stitch stays over there. It means there is no tension. Can I have another one? Smaller one? So, for the first time, we have advised absorbable suture, and for the first time, we have advised a continuous suture. Don't cut. Follow this. This is continuous suturing. It's very simple. See, with this index finger, you retract or protect the vessels. This is inguinal ligament. This is the upper leaf. He is lifting up so that inguinal ligament stands up. You have to lift it up. So the inguinal ligament stands up. You can take this part little bit so that it gets fused together properly. You need not take also. Posterior, that is a pseudo fascia. There is never transversalis fascia over there. What you see is posterior lamina covering the fat or the pseudo fascia. This is internal ring is to be sufficiently narrowed. That is very important. That's okay. Yeah, you see, this is, I think that this should be the last stitch. You need not go further. So that it is sufficiently narrow. Internal ring is sufficiently narrow. Right. This lateralization of the spermatic cord is not really lateralization. It is where bringing this spermatic cord back to its normal position, which otherwise had got shifted medially due to herniation process. Yeah, if he has got indirect, procedure remains same. Second step is we take an incision through this sutured upper leaf. Now this incision is taken in such a way that you prepare a strip of 1 to 2 centimeters wide only. Then go medially till you should always go parallel to the inguinal ligament. This is how I am going parallel to the inguinal ligament. Then laterally we extend this incision for 1 or 2 centimeters beyond the internal ring. This is the internal ring and this is the 1 or 2 centimeters beyond. Now you will find the strip is separated. This is the strip, artiforceps. You see, this is the strip, okay? Lower border of the strip is already sutured to the inguinal ligament. Now this upper border will be sutured to the muscle arch. Again with PDS absorbable number 1 suture. Here you should take as far as possible aponeurotic part of the muscle. But if aponeurotic part is not available, it is not seen in this patient, you can use muscle only, direct muscle. Follow. Again continuous sutures. Yeah, we are waiting for you to come back. And
we are again with you.
oh, that's fantastic. You see, now I have prepared the posterior wall. You can see this. This is the lower suture line, this is the upper suture line, and this is the aponeurotic strip, which is continuous with the muscle. In fact, if it was local anesthesia, then I would have asked patient to cuff on operation table to show that this strip is physiologically dynamic. The smaller the cuff, smaller is the contraction, larger the cuff, larger is the contraction. That's how this, I have prepared a physiologically dynamic and strong strip to give complete cure from herniation. Operation is actually complete. I was waiting for you to come back. This cord is placed in its own place again, and the lower leaf and the upper leaf are sutured in front as usual. I have put the cord in its own place. Now this is the lower leaf. Hold it, another artiforceps. And this is newly formed upper leaf. I'll just show you. This is the newly formed upper leaf. Got it? This lower leaf corner and this upper leaf corner will be sutured together. In front of.
I have problems to close it.
No. If you,
people or something like this.
yeah, maybe, but then if you follow this procedure completely, undermining of the upper leaf properly from above and behind, and not to take too wide a strip. And one more thing, which in this patient I didn't show you, but then there are adhesions over here, see in the groin. If you release those adhesions, this, you got it now? It becomes free. We use PDS 1 number absorbable suture. 1 packet is sufficient to complete the operation. So you save 1 packet of suture material also in each patient.
Okay. Looks very nice. Any questions?
Now this will be continued till superficial ligament. Forceps.
There was a question from the audience.
Yeah, what's that?
Did you check the traumatic cord for an indirect hernia?
No, yeah, in indirect hernia, you have to do herniatomy as usual. Herniatomy you have to do as usual. Rest everything is same. The steps of this operation are same, whether it's direct hernia, indirect hernia, pantaloons hernia, recurrent hernia, or any hernia that requires repair. Steps are fixed.
Okay. Any hernia.
Dann können wir das ja als Abschluss.
Dr. Desarda,
Yeah?
thank you very much. We will change to Ms. Pratt and then go to Otto.
Danke.
Thank you.
Okay, thank you very much, Professor Desarda. Sir, you have really tried best to impress the audience that open hernia surgery is the go of the world. Laparoscopy is no answer. In fact, Dr. Bhatia tried himself best that laparoscopy is the answer, and you tried your best that no, laparoscopy is just gimmick. It's all marketing policy. It's just commercial. Yes, please. Please.
Dr. Sahoo,
Yes.
if you go to any junior surgeon,
Okay.
they will all know about my repair.
Yeah, I know, sir. I still also agree with you that in United States of America at the present era, at the present time, maximum of hernia repair, the best of places are done in local anesthesia, open surgery. I agree with you. I still agree with you. Yes, laparoscopy is not possible in every nook and corner of the country. Not every surgeon can replicate the best of best repairs in laparoscopic repair, whereas your repair is replicable. It can be done with the most junior surgeon. It can be done with any surgeon at any nook and corner under tree. Also, it is possible. You don't require an operation theater as well. I mean, you made it so possible and so pleasurable. So before I open the floor to the audience, just for the debate to start happening, I have a few questions to you, Desarda sir.
Yes.
Your first thing is that yes, it can be done under local anesthesia. Any surgeon can do it for whether it's a direct hernia, indirect hernia, pantaloon hernia. This is the answer. Fine. I just won't believe in one thing, that you are taking the external oblique aponeurosis, a strip of the aponeurosis, which is in fact acting like a mesh on the posterior wall, that's giving all the support. But this same aponeurosis is at the bottom end to the inguinal ligament, and to the superior edge it is anchored to the muscular aponeurotic arch, or even at some point to the muscle itself if it's not, the aponeurotic arch is not available.
Right.
How is it physiologically, I mean, leaving aside the physiology, how is it biologically tenable for an aponeurosis to get anchored at one end to the inguinal ligament and to the other end to a muscle?
That is the
We
miracle.
are not coming. Yes, please.
That is the miracle of body. Any tissues they heal.
Yes.
Whether it is aponeurosis with muscle, muscle with muscle, aponeurosis with aponeurosis, the art of healing is a miracle in our body, and that is what is giving us the upper hand. Whereas Dr. Bhatia, I'm sorry to interfere about that. He talked about the collagen theory. Red, who publicized this collagen theory, he never talked about the external oblique aponeurosis. It was just an accidental finding that in smokers' lung there were increased number of aortic aneurysms, and he found more number of hernias. That cannot be a proof. But then later on, mesh people picked this up to counter the tissue repairs. But my question to Dr. Bhatia is, if your collagen, this thing is not working properly, then worst affected will be your mesh repair. Because mesh repair depends on the fibrotic reaction, laying of the fibrotic tissue, and preparing a shield, fibrotic shield on the scaffold of the mesh. Mesh per se doesn't give any protection. Whether you put it through mouth or through other source, doesn't give any protection. It works only as scaffolding. I'll ask some more questions, but I'll ask those questions after.
Sir, in fact, Dr. Bhatia is beaming with happiness because he knows that he has so many followers in this audience. People will be happy and so much enthused with laparoscopy than in open surgery. That's why he is very confident. Okay. But I mean, let me come to that. So, Desarda sir, yes, you are absolutely right that mesh doesn't play any tricks. It doesn't play any gimmicks. It's the scaffold which actually create all the things that's happening around. But I think time and again, in multiple centers across the globe, multiple surgeons across the globe have proved that the mesh is the only answer, and to the point that it has come to been a dictum also, that if you are repairing a hernia, you have to put in a mesh. No mesh, no hernia repair. It is as simple as that. But
Who said that?
Desarda sir, you are still pursuing that. Yes.
Dr. Sahoo, let me be
Yes.
clear. Who says that? Mesh manufacturing companies say that. I'll send you a video.
No. Okay.
I'll
Okay.
just send you one video.
Sir, at one point, one
Hello.
surgeon was putting a mosquito net, and
Just
he
to-
was claiming that this mesh is also a gimmick. Mosquito net also can replace the mesh.
Just two sentences.
Yes,
There
sir.
was a study done in America itself by one doctor, and she has clearly said that everything is money, money, and money. Nobody is bothered about the patient's health, and we must accept this. Everything is concerned with that. But
Sir,
then, I have some questions. When you can operate easily under local anesthesia, patient comes walking, go in our Florida center. We have a center in Florida, Desarda Center, USA. There, patient is not at all admitted. It is daycare center. Patient comes, get operated, sits in the car, and goes to hotel or his room. And the results I have already stated, not my own result.
sir, I agree to your statement that it is a walk-in and walk-out procedure. You take care of the inguinal, be it inguinal, be it femoral, be it direct, indirect, femoral, you are taking care. But what about those obturator, femoral, what to that? What to that missed hernias? What to that lipomas of the cord? Things which are really bothersome to the patient many a times.
I'll
So
answer.
how you address to that?
I'll answer.
Yeah,
Of the cord is always tackled with the open repair.
sir.
Okay. Femoral hernia, I never advocated my operation technique per se from the beginning. But
Okay.
now some surgeons are doing this by just little modification. You see, I advise you to suture upper leaf to the inguinal ligament. There I said that you suture upper leaf to the pectineal ligament in half part. And half part, lateral half part, go against, jump again to the inguinal ligament. Once it is sutured to the pectineal ligament, your femoral hernia is finished. It's taken care of.
But what about the obturator hernia? And what about this Prussard's concept of myopectineal orifice?
Yeah.
Sir,
See,
what about Prussard's concept of myopectineal orifice? In a laparoscopic repair, a surgeon is covering the entire myopectineal orifice.
sorry. Obturator hernia doesn't come in myopectineal orifice.
Yes.
It's correct law.
Okay.
First of all, there are so many hernias. We are talking about myopectineal orifice, femoral hernias, and inguinal hernias.
Okay. Right.
My operation technique is the answer. The only objection which was raised world over by many stalwarts, that what will you do if external oblique aponeurosis is weak? Somebody might ask this question to me.
Yes.
I can answer that. You see, aponeurotic structures are least affected by aging process. That is accepted fact. Whatever you see, for example, a large hernia, you feel that there is an entire floor is filled up with a weak aponeurotic, weak external oblique aponeurosis. It's wrong. It is not external oblique aponeurosis. It is the sono fascia over there. When hernia becomes larger and larger, these superficial ring fibers, they tear off and start separating. So upper lip remains intact, lower lip remains intact, and whatever you see in between, entire field is filled up with superficial ring. All the tissue over there is not weak external oblique aponeurosis, but it is the pseudofascia. So you forget about that, operate, do herniatomy as usual, and you will find upper lip very well can be sutured to the inguinal ligament as usual. We operated on coconut-sized hernias, you can imagine. There are some 1 or 2 articles also published by one surgeon in Nagpur. Giant hernia, giant inguinal hernia. It is worth reading. The results are excellent because the concept is excellent, because the concept is different. Let me tell you, it is very hard for some people to accept what I am doing. But people like you who are unbiased, they will definitely appreciate, and you are appreciating it. So I'm really thankful to you. And of course, I will be thankful to Dr. Bhatia.
So I think by this time Dr. Bhatia is also very much convinced that he will from tomorrow he is not going to do any laparoscopic repair. Tomorrow, first person he will be meeting, he will advise him a Desarda's repair. So I mean, we'll come to that. We'll come to that. But
Sure.
I think one point that you have tried to convince the world, it's a worth effort. I mean, from the beginning, I have told we are not here to underestimate a procedure or overestimate a procedure. We need to be scientific to give the best to our patient, whatever he requests. We have a cafeteria at our command. We need to choose which one is better for our what situation. It's not about the open or laparoscopy. So no one is biased here. No one is telling that laparoscopy is superior to open. Neither I am convinced that open is superior to laparoscopy. I think Dr. Desarda, you have right from the beginning also have told that you are not never against laparoscopy. You also welcome that it's a boon to the mankind. But we also agree to your effort that laparoscopic repair is not replicable everywhere with every surgeon with equal competency. That's absolutely a fact. That's absolutely a fact. No denial to that fact. Your technique is so simple, so simple. It can be replicated even by my OT technician. Forget about the resident. It is so simple. Anybody can do that. You just take stitches to the inguinal ligament, cut it 2 centimeter above, and this the upper end of the external oblique to this the lower end of the external. It's over. There cannot be anything simpler than this. Then why the world is moving towards this? Your only point. I will now come to Dr. Bhatia that Dr. Desarda's whole statement is open hernia is the only answer. Laparoscopy is no answer. Laparoscopy is all marketing gimmicks. It is only company driven. It is a publicity driven. It is corporate driven. Everything. I think Dr. Desarda is also happy with my all statements because I'm taking his mind. I'm reading his mind. So it's fine. So Dr. Bhatia, how far you agree to these statements that it's absolutely not scientific? MES is not doing anything. So even Lichtenstein that he told that Lichtenstein is the gold standard repair in open hernia repair where he had recommended a MES. Dr. Desarda is convincing us that MES is absolutely not the answer. It is not doing anything. It is rather creating a scaffold which is giving all support. In place of that, why not a tissue? When somebody is blowing, the tissue, this strip is in fact coming into action. Whereas in MES, it is a complete scaffold. It is whether you are blowing, whether the pressure is rising or falling. The scaffold doesn't change anyway physiologically. So how you defend to these statements of Dr. Desarda sir that everything is marketing gimmicks, everything is commercially driven, not a scientific fact. So how far you stand to this?
I honestly appreciate the passion which Dr. Desarda is having about open surgery. But I must ask him that how many surgeons he has been able to train and how many in totality hernias have been done by Desarda technique. It is not the open surgeon, it is not the laparoscopic surgeon, the patient is the god. And patient is the person who ultimately markets it. I presented that in 1988, when I had written a thesis on shoulders repair, then I had on the first page of my thesis page was a photograph of a patient who was having the hernia for 34 years. And his answer was that when I asked him, why did you not get the surgery done? His answer was, I am afraid of pain. I am afraid of surgery. I am afraid of surgeon. And I am afraid of the complications. And that is the reason that I did not go in for surgery. So what I mean to say is pain from open surgery vis-a-vis laparoscopic surgery, patient derives, not the corporate. Not the corporate, patient drives. If the tissues were as good as Dr. Desarda has shown, then there would not have been any recurrences. you know the tissue repair had failed, and it was not, I would not say that Dr. Desarda is not doing a good job. He's doing an excellent job, but he has not been able to train world over the surgeons so that they are also able to give this duck recurrence. He is not able to do it. Neither. So our thinking is that if the tissues were good enough, they would not have recurred. The tissues are bad. That is the reason that you need a reinforcement by the mesh. And once you do the reinforcement by the mesh, the tissues, I am not again believing that collagen deficiency is there in everyone and that is why the recurrence is there. No, but if you place a reinforcement, then the tissues recurrence is definitely reduced. So thinking is that laparoscopic cholecystectomy, all of us know it was the deriving force was patient, not the randomized control trials. So if the patient finds, and believe me, Dr. Desarda, sorry to say in a lighter vein, one of your patients, he came to me 5 days back only, and he said that I want the Desarda technique. So I told him that we are going to have a debate. So I said that what do you know about it? And frankly speaking, day before yesterday, I did his laparoscopic surgery, not because of anything else, but because of the chances of recurrence. That I told that what is the recurrence rate after open tissue repair? What is the recurrence rate after open mesh repair? What is the recurrence rate after you go and search the literature and then come back to me? And then he said that yes, I will go in for duct recurrence or laparoscopic TEP repair. So our thinking is just a sec. Our thinking is yes, sir, just a sec. So our thinking is yes, we are advocates of a excellent hernia repair for the patient. There is a subset of patients who will require the tissue repair, as I mentioned, the strangulated or different kind of situations. But for recurrent hernias, I don't think so that one can offer the tissue repair. For recurrent hernias, no, tissue repair does not hold good. So for primary hernias, for thin BMI, for 25 BMI, yes, it is an excellent procedure. Local anesthesia is a good procedure. But if the BMI is, we are settling maybe 38, 40, 45 BMI, and if I start instilling local anesthesia, and if I am not able to even go into the anterior aponeurosis, then I will not be able to do the justice. My thinking is one pant does not fit all. One has to make sure that one should learn the open, one should learn the laparoscopy, one should offer according to the patient rather than one tissue repair fits all. That is not a right approach.
So I think Dr. Bhatia is, Desarda sir, before coming to you, I must answer to Dr. Bhatia's questions also. I mean, Dr. Bhatia raised a very pertinent point that open hernia repair by your technique does not ensure a zero recurrence. Dr. Bhatia, do you also ensure a zero recurrence in laparoscopic hernia repair? Absolutely, probably no. Zero is a myth. Zero is absolute a myth. In this process, I get reminded of my post-graduation days when one of my teacher was doing a inguinal hernia repair with Bassini's technique with a catgut suture. He was afraid of giving a Prolene suture. So once I asked, sir, why are you not using a Prolene suture in inguinal hernia repair when everybody is using Prolene? No, I have never got a recurrence. But sir, all your recurrences are going to the other surgeon in the department. They are not coming to you. So, I mean, it is just a corollary I am giving. So you also agree that laparoscopy is not the answer for everybody. Open also has to be there in the armamentarium. Yes. And you also tell that every surgeon should get himself equipped with open repair as well as laparoscopic repair. Is it, Dr. Desarda, that's because you are not trained in laparoscopic surgery or you are not doing laparoscopic surgery, you are having a thinking that everything is commercially driven, not scientifically driven? No. Okay, sir, please come forward. Please come forward.
I told that laparoscopy is a boon to the mankind.
Yes.
Only against the mesh and through the laparoscope, when we can really go inside through the skin incision. And by the way, I think that patient contacted you by email, Dr. Bhatia, first, because I had given your email to him to contact you. Just,
Okay, that's great. Okay, I mean,
I
then
just wanted to see how much senior surgeons are ready to accept what is going on in the world. How much they just want to push their own thinking, and that affects students. Your thinking affects students. That is my grievance. That at least we teachers should be absolutely unbiased and should talk of everything, good or bad. You can talk good about me, bad about me. You can't say laparoscopic is the answer. You cannot say that.
absolutely. I
never said that.
Let me tell you how many recurrences I have treated in laparoscopy after post laparoscopy recurrences. How many patients have? One surgeon from Russia got his bilateral hernia operated through laparoscope. His life was ruined. He was unable to walk. And he was in constant contact with unfortunately, I am not a laparoscopic surgeon. But then I advise you get that mesh removed, otherwise your life will be finished. So there are many things which are in favor, and you have to see which is better.
Yes, sir. Desarda, sir, I agree with you. Chronic inguinal hernia is a very, absolute complication. Is such a complication, nasty complication that no surgeon ever wants to get his patient get into this problem. But at the vis-a-vis, a open hernia surgery also post-op neuralgia is also a complication. I mean, you can't also say same time that my operation patients are not having any pain.
Okay.
They are also having. Yes.
I agree. Yes. No surgeon will wish that his patient should have any problem. I agree.
Absolutely.
I have just one question, sir, Dr. Bhatia, sir. How many laparoscopic repair normally you do in a year?
I would say that around 50 to 60 per month we are doing.
Per month. So it's 500 to 600 every year. How many of them are bilateral inguinal hernias? If we take it 10%, is it okay?
Yeah.
So it means 50 to 60 patients are operated for bilateral inguinal hernias. Now, single surgeon Dr. Bhatia is doing those many surgeries by laparoscope. You can imagine millions of surgeons who are doing laparoscopic repair in the world. And I have shown you one picture. The mesh is directly laid on the vas and the testicular vessels. Now you can't say that it won't affect vas and testicular vessels. Now when it affects vas and testicular vessels means though many millions of patients you are exposing them for partial sterility. And those bilateral inguinal hernias which you are insisting is a benefit for laparoscope to do laparoscopic repair, you are pushing them into the total sterility. Don't you agree with this?
No.
I think all trials have really proved that probably mesh is not creating a problem from that point of view.
Send me even a single article which is published on this.
And Desarda, sir, if you tell that all articles and publications are also commercially driven, then I have absolutely no answer. I have to raise my hand.
But no article published on this till today.
Yes. Yes.
No, but honestly speaking, answering to your sterility, and if you say that all the methods cause problems or they cause reactions to the vas,
I said you are exposing them.
No, but believe me, it is over-exaggeration.
No, before you are...
Manash, I think it is good idea now to encourage the audience.
Audience to participate. I think if we take an audience poll, how many of the audience actually in favor of open hernia repair? Just to get a audience poll, I will post this poll now. I'm starting a poll. How many are for open? Option A.
Lab.
I mean.
I think everybody has polled for me.
Okay. And the good thing is, Dr. Bhatia, when you told, Desarda said, told that probably many surgeons are not able to do laparoscopy. When you told that how many surgeons you have trained in your technique. Probably Dr. Desarda doesn't need any surgeon to get trained. His technique is so simple. I told her any OT technician also can do it. Forget about a surgeon.
No, Manash, just tell me that if this kind of repair, tissue repair was excellent, then why would we see so many recurrences?
Yes.
So many recurrences.
Dr. Bhatia is confusing in two things. You are talking
Maybe
about
it's a defective repair.
tension repairs, and you are comparing old tension repairs with my tension-free repair. I have given you a data of 31,374 patients, 66 RCTs, 50 new studies. What more you want? What more evidence you want?
No, but I can give you so much of data of number of laparoscopic hernia repair which have been done world over. World over, from 93 onwards, too many laparoscopic surgeries have been done. But thinking is, again, I am again reiterating the same, that there, till date, there is no one technique which will fit all. One should know it is an excellent procedure. Desarda is an excellent procedure. Laparoscopy is an excellent, but one should never ever say, because I will go on a bullock cart because I cannot afford the car, I will go to a distance on a bullock cart. Why? Our thinking is that yes, one should know that car takes you faster or aeroplane takes you faster. We should not go back to the 30 years, 40 years, 50 years tissue repair, which had been discarded by one and all after the failure of bases and shoulders, and then came the era of mesh. But definitely it is good to stand and then put in the viewpoints and learn from all of us, and then ultimately present. Yes, sir.
I have already answered why Bassinian shoulders have failed. It is not the fault of the original author, my dear sir. He has shown 4% only recurrence rate. It is we who have modified the first step, which was very complex and risky dissection. I tell you, common general surgeon wants a surgery which is very simple, without any complex dissection, without requiring any higher skills, and without requiring any up-to-date operation theatre, high-tech operation theatres, etc. But then if we have modified, now shoulders, now tell me what is the recurrence rate in shoulders? They are even now doing all sorts of modification.
Sure.
They have come down to 2 layer now. Instead of 4 layer, 2 layer.
Modified shoulder.
In fact, in my lectures, I have always stated, in fact, shoulders operation is a mesh operation. Bassini is much better. He just made some little changes. Instead of 1 layer to 2 layer suturing, stamped it shoulders, started marketing and popularized his technique. And I am sorry to say that many senior surgeons I have seen during my lectures standing and proudly telling, I went to the shoulders hospital for training, and I am doing it for the last 10 years and 20 years and like that. You should be open to understand.
I think Desarda sir, I think we have really agreed, both of us and rather 3 of us, that no one technique is superior to the other. Both are really good. Desarda sir, yes, we agree, and I also agree with you. Your technique is replicable in the hands of any surgeon.
When any surgeon says tailored concept, means surgery should be chosen as per patient's this thing. That is the point where he is defeated.
Okay. So I mean,
he comes with this excuse that he should be tailored.
okay, I fully agree with you that your technique is so nicely replicable that it doesn't need further training, upgrading, learning the anatomy, so many of complexities in laparoscopic repair, of the learning curve, so many factors involved. I mean, they are probably not there in the Desarda repair. They are so, it is so simple.
Actually,
and,
when
yes.
you said Dr. Bhatia is there, I was excited and very much happy, because he is a person who accepts.
Yes.
Or he doesn't accept, he tells.
I mean, I have also very wisely chosen speakers. I am not also that fool to choose a speaker. I know who will accept, who will not be adamant in his own technique. I know he is flexible. He will not have a direct fight with you. No, laparoscopy is only answer, open is out. No, it is not like that. Right from the beginning, you also told that laparoscopy is not bad. That is also boon to the mankind. You only disagree to the mess. Probably if laparoscopic repair is also done without a mesh, you will agree to that. But
Oh,
unfortunately,
I wanted some surgeon to come forward and do this technique through laparoscope.
yeah, that's what I meant to say. But unfortunately, that failed. People had tried to repair laparoscopically, but that didn't stand. It all gave way and there were recurrences. So in the meantime,
if you could do, you will be the world-known famous person, let me tell you. And it will label like Sahoo's repair or Bhatia repair.
okay. So let us now take questions from the floor. There are questions. If you have a bigger defect, wider defect, Desarda sir, what will be your technique then? Because bigger defects are absolutely not a problem for laparoscopy. I mean, how big the defect is, we are not bothered. So how you manage a wider defect?
That's what I told you. We have operated on coconut-sized hernias also.
Okay.
See, the origin
is not remains all same. The technique doesn't change anyway.
No. And origin is never wider.
Okay.
See, it's only in direct hernias you will find entire posterior wall is sometimes involved in the sac herniation. Simple. Just take a circular stitch, push it inside. Finished. Your involved canal is open for your repair. And do it as easily as it can be done.
Okay. So, I mean,
from the audience?
Yes, this question is from the audience. I am now taking from the question from the floor. Okay. So somebody had asked that if you have a bigger defect, how you manage? Probably essentially you don't change your technique. Your technique all remains the same. So also in laparoscopy, the laparoscopy technique doesn't change. Yes, some modification, some or other happens just to prevent seroma. You agree to me, Dr. Bhatia, if you have a wider defect and just to avoid seroma, you fix in the sac inside so that the patient doesn't have a post-op seroma. That's in fact one of the very common complications that happens. Probably Desarda repair doesn't have that, nothing to worry about the seroma. Am I right, Desarda sir? You don't have anything to worry about seroma.
Not only seroma, don't have to worry about chronic pain. You don't have to worry about seroma, like this hematoma, infection, anything. Nothing is there.
Okay.
You can operate in all the patients, irrespective of staging of the hernia, irrespective of grading of the hernia, irrespective of the typing of the hernia. That is the greatest advantage with this repair.
Do you give any scrotal support also after your repair? You prefer that?
If the hernia sac is quite big, inguinal scrotal hernia, and your dissection had gone to the scrotum, then you better, if there is scrotal swelling, you will give little scrotal support. There is no harm in it.
Okay. Then there is a question. Would this Desarda repair be a good choice instead of a biological mesh in case of strangulated hernia requiring resection of the gut? Dr. Jinesh Doshi asked this question.
What is that? Biological?
In a strangulated hernia, we prefer a biological mesh.
In fact, many surgeons have recommended Desarda repair for strangulated hernias, infected hernias, if not for all hernias.
So you have the advantage of doing in any kind of circumstances. Whereas Dr. Bhatia, you'll agree with me that we have to stay back if it's a strangulated hernia. Then our protocol and everything have to change. You cannot do the same.
But believe me, we always say in a case of strangulated hernia that we are not going to place in a mesh, and you may have the recurrence. And once you have the recurrence, then we'll do by laparoscopic method. What I mean to say that the primary thought has to be changed. If Dr. Desarda wants it to become a universal technique, then the primary thought has to be changed that yes, the tissue repair has still got the recurrences. The reinforcement mesh is a must, and mesh definitely has reduced the recurrence rate to around less than 75%. So our thing is, again and again, we can debate that. I am not denying that. But my
is referring to only those articles which are published in favor of the mesh. I have those articles which are clearly stated in last 10 years, mesh has not given any advantage over the tissue repairs as far as recurrences are concerned. I can send you a list of those articles to you. See, forget about those articles. Let us come to one-to-one position.
Okay. Now I request the audience to make themselves visible and ask directly the questions to Dr. Desarda and Dr. Bhatia. Could you be visible? Anybody who is interested to ask, please come forward. because you have all listened to an excellent debate going on between open surgery and laparoscopic surgery. I think
Yes,
we
sir.
have nearly come to a conclusion that both are good. Yes, Dr. Fadi, you are from which country?
I am working in Saudi Arabia at now, general surgeon specialist,
Okay.
level of consultant, 16 years experience,
Okay.
MRCS and study of RCS.
Right. What's your
Thank you, sir,
question? Yes.
for a great lecture. We learn a lot of this, but my comment will start by hernia identification. Hernia are a collagen disease with reduced collagen type 1 to type 3 ratio. So this is the international or global identification. I cannot change myself. So if I want to repeat, I want to study the patient. I want to study many ways. Always is correct, but maybe all ways, all technique not suitable for this patient. So every patient maybe is good for Desarda, other for laparoscopic. So my opinion, to put indication for Desarda and indication for laparoscopic. This way will be fair way for always. We can tell tip better than tab or Desarda. We will put indication for every one. By this way will be fair way. And thank you to allow me to share my opinion.
Yeah, I think we have nearly discussed all your thoughts. Both the techniques are good. A surgeon need to learn laparoscopy as well. Surgeon cannot also give away open repair. Open repair is not totally outdated, but you have to choose which procedure is better for at which scenario. That has also been discussed, and no one, neither of them have told that one is much superior or comes with a zero recurrence. That's absolutely not a fact.
Yes, sir.
It has recurrences, but
Recurrence.
yes, Dr. Desarda tells that his procedure and his technique is very simple. This can be replicable at anybody's hand. And laparoscopic repair, yes, it has a learning curve. You need to orient yourself, you need to upgrade yourself from one technique to the other technique, but that's the way that we move forward. But Dr. Desarda doesn't agree to that, that all this advancement is not required. Probably the world is all commercially driven in blindly following one technique or the other. That probably nobody will be surely believing and agreeing. And Dr. Bhatia is laughing, means probably, sir, you also agree with me that the world will never agree to that. But Dr. Desarda is almost fixed in his mind that this entire world is probably going one way. No, no. So only mess is the only factor he doesn't agree to that.
Whenever I say something, it is not
Yes.
applicable to everybody. You see,
Okay.
out of 100 people,
Yes.
10 people are driven by these companies.
Right,
Not
right.
90 people. And let me tell you, those 90 people are pushing my technique in the world.
Okay, good. I mean, there are bad apples in every profession, so no profession is an exception. So neither also a medical profession. So I can't say or argue on that. So Dr. Fadi, I think you are convinced with the answers. Yes, Dr. Bhatia, you are giving.
Dr. Fadi, I would say that if the patient is having bilateral inguinal hernia, if the patient is having recurrent inguinal hernia, definitely laparoscopy has the answer. And if the primary hernia is there, then Dr. Desarda is also the answer, and laparoscopy is also the answer.
But Dr. Desarda, do you agree to this? Even a bilateral hernia, even a recurrent hernia, ever a recurrent hernia, also Desarda repair is the answer. Do you agree with him, sir?
No. I agree with him. I agree with him.
Okay. So what is your thinking on this? If a bilateral hernia?
Why?
Yes.
I'm telling you why. Recurrent hernias, your mesh damages everything. What is left over there? Is external oblique aponeurosis left over there? Is intrinsic muscle left over there? And everything becomes fibrotic. How can you do Desarda repair in such cases? It means you spoil the show and then call Desarda to clean it. No.
Okay. I mean, then you fully agree that if there is an open recurrence, laparoscopy is the answer because the surgeon is accessing in a virgin field.
If
Fully agree to that.
If it is with mesh, then
Yes.
also you can do Desarda repair.
Okay, okay. I mean, when a laparoscopic recurrence, you want an anterior repair. That's probably a standard dictum. But quite often now also laparoscopic recurrences are dealt laparoscopically. We are comfortably doing also laparoscopically, and patients are getting good results. Yes, but I agree.
Now
I agree with you.
Come.
Yes.
Are you going to put inside?
No, no. Okay. Great, great, great. Any other question? Yes, Dr. Sinde, you want to ask anything?
Yes, sir. There is one question for
Sure.
Desarda, sir.
Yes.
Many of the times we see that the external oblique aponeurosis is at many places it is weak, and in such cases, even if you want to go ahead with the Desarda's technique, how to go with that? Because there is at multiple points there is weak external oblique aponeurosis.
I think I have already answered this, but then I'll repeat it again. You see, large hernias or where superficial ring is almost occupying the your operation field, then you feel that external oblique aponeurosis is weak. But in fact, it is not external oblique aponeurosis. What is it then? As hernia enlarges, it tears apart the superficial upper crux and lower crux of the external oblique aponeurosis to become a bigger superficial ring. So upper leaf remains intact, lower leaf remains intact, and what you see in between is pseudofascia. So just excise the pseudofascia, do your herniatomy as usual, and upper leaf you can easily complete the procedure as per my technique. No problem. That's why I said we have operated on coconut-sized hernia, not one, two, many. And there is one article published by even Nagpur surgeon, a giant hernia, involved hernia, treated by the Desarda technique. Excellent results.
So I'm not talking about the giant hernias, but I was talking about the weak, where there are multiple strips that they fragmented external oblique aponeurosis.
I think you are confusing. It's not weakness. It is separation of the fibers.
Yes, yes. At that point, separation of the fibers.
Yes,
in that case,
actually, I have published my book that Dr. Sahoo was kind enough to show you also. I have given in detail everything with photographs. How to tackle in some patient whenever there is fiber separation. Don't worry, you separate a strip in such a way if possible in between two fiber separations. If it is not possible, just take small loop sutures to approximate those separated fibers together and prepare the strip. Simple.
Sir, may I request you to send the books to one and all who are attending the webinar?
110%. Dr. Sahoo, please send me.
Yes. Yes, I mean, surely, Dr. Desarda sir, it will be a pleasure for every attendee to have your book. So also, Bhatia sir, also you can share your book also. It's absolutely not issue. There are lot many publications also I have got in favor of laparoscopic repair. I mean, these are things always to be cherished for. Yes, sir. Desarda sir, you are telling something.
In fact, you can imagine medical books. I am not interested in selling the books. I am interested in the books. And the answer,
I know. You want to increase the awareness of that your techniques across the world. Yes.
Answer is because you can imagine what is the cost of any medical book published on the Amazon. Any small book will cost you at least $300, $200, $500. You can imagine what is the cost which I have kept for my book. Can you imagine?
$10.
Anyone? $4.9.
Great. It's like the Desarda repair itself. Okay, Dr. Ravi Shankar Malviya, sir, you want to ask something? Yes.
I very much welcome the proposal from Dr. Bhatia, and that will be a very special gift to us.
Yeah, it will be surely gone from my end. Dr. Desarda will send his books to me, and all of you please send me a mail at manash67@gmail.com. I will just coordinate that the books will reach you. Absolutely.
One more thing.
Yes.
Instead of that, if you go to our website, desarda.com.
Okay, desarda.com. Right.
Desarda.com.
You have kept things very simple. Desarda repair, desarda.com. It's easier to remember. Okay, fine.
Repair name is given by other people, not by me.
Okay, great.
Desarda.com website gives lots of information, and we have enlisted all the articles, 200 articles published or presentations made. You can approach all those articles on our website, desarda.com/articles.
Okay.
And if you want to send an email to us, email address is very simple: desarda@hotmail.com.
Great.
Or desarda@desarda.com.
Sanat Mahapatra sir, you have any questions? You are muted. Please unmute yourself. Professor Sanat Mahapatra sir was in fact my teacher when I was a postgraduate. So there are so many of my teachers who are in the audience. There are around nearly 180 people when we were on the peak of our time. Yes, Sanat Mahapatra sir, please. Hey, you are muted, sir. You are muted. Please unmute yourself. You are muted. Sir, please unmute.
You can unmute him.
No, I think he will need to unmute. Okay.
Now am I audible?
Yes, you are audible, sir. Yes.
Hello.
Yes, you are audible. Please.
Am I audible now?
Yes. Yes, you are audible, sir.
He is not able to listen.
Sir, you are audible. Please go ahead.
Am I audible?
Yes. I think he is not listening.
Yeah, I think
He is not able to listen. Dr. Sibacha Mahapatra, sir, you have anything to ask?
Manash.
Yes.
Dr. Doshi wants to. Jitesh Doshi.
Yeah, please, Dr. Doshi, could you just unmute yourself? Yes.
Yeah, I'm audible now, right?
Yes,
okay.
Yes.
I just wanted to say that we are comparing a laparoscopic surgery versus a open surgery which does not use mesh. Actually, we should compare open surgery with mesh and without mesh.
Okay.
These are absolutely two different things that we are trying to compare. Actually, we should compare a mesh repair open and open surgery without mesh.
I think open surgery with mesh is already a known phenomenon. Lichtenstein repair is a gold standard procedure. There is no confusion on that. Probably Dr. Desarda also is not telling that is a technique which is to be discarded. He is not telling that. He is telling that mesh should not be used. In place of mesh, he can use a strip of tissue. That's
no, but he has tried to show disadvantages of mesh along with the disadvantages of laparoscopy. He has combined the two disadvantages while trying to prove the superiority of his procedure.
I think he needs to know, are there any comparative studies comparing my repair with tissue repair or my repair with laparoscopy? Let me tell you, if you go to our desarda.com/articles, you will find many articles comparative studies comparing my repair with TEP, my repair with TAPP, my repair with Liechtenstein repair, or my repair with Scholdeis repair, my repair with Gassini's repair. I think when I showed the data, probably he wasn't there. I have shown the data, 66 articles and 50 studies were there, already conducted. So all these studies are already done, and you can get all the articles from my website.
Dr. Desarda, I may in a lighter way that my repair should become our repair.
What's that?
Yeah.
I said that my repair should become our repair. Then that is the
Anyway, since it carries his name, maybe Desarda is telling it's my repair. anyway, that's great. I mean, Dr. Sivacha Mahapatra, sir, you want to ask?
Yes, Professor Manash.
Yes,
Professor Manash.
Yes,
very
sir.
nice, very nice to hear the debates of open surgery and laparoscopic surgery.
Yes, sir.
There is no comparison of a bull cart, bull cart and plane. You see, this is not the real simile. Desarda has his own advantage, as you have rightly commented. For in the periphery, when the technology has not reached the beginners for learning curve development, but for the advanced centers like All India Institute, you are working, you are training people. That is not possible in every center. So Desarda has the advantage of a basic training and giving a good repair in the initial phase of career. But in the advanced stage, when goes on learning curve, when goes on the residency goes into a senior residency program, then I think laparoscopy should be practiced by the surgeon because it has a lot of advantage for recurrent hernia, for bilateral hernia, for hernia in obese patients. When you feel the collagen disorders, there is probably the external oblique aponeurosis is broken. Many times we find in hernia, the oblique aponeurosis is broken into pieces, multiple pieces. There, Desarda is not coming to help us. So that where
So I think you are telling that when somebody starts up surgical career, probably he will be happy with an Alto, and as he progresses up, he will be wanting a Mercedes and Audi,
yes,
something
we
like
can say
that.
that. Yes,
I
yes.
think okay. In that context, I am reminded that our residents not getting interested or getting trained. Till now, probably I had whatever residents were given a thesis or some research work to be done, and always all on laparoscopic hernia repair. But when I came to AIMS, I was telling that one of the resident, I was surprised to find one resident is doing Desarda's repair, and he is also amongst the audience. Yes, Dr. Ankit, could you be visible? He has passed his MS from AIMS Bhubaneswar. He is now a senior resident in the same institute. So he was doing your technique, sir. Dr. Desarda, he'll be happy. In fact, 3 days back, I asked him, have you seen Dr. Desarda? I asked him, what is the full name of Dr. Desarda, the thesis that you did? So he was fumbling. He was not able to tell your full name. Then I asked him, 3 years you did a thesis on his work. You didn't bother to know his full name. Then he told your full name. Then I asked him, have you ever seen him? No, sir, I haven't seen him. Well, I will give you an opportunity to meet him. So
yes.
please meet your student. Yes, Ankit, you can go ahead and say hello to Desarda, sir. Yes.
Hello, Ankit. How did you find?
Good evening, sir. Good evening, sir. First of all, sir, I would like to thank Manash sir for giving us this opportunity to listen to this wonderful debate. And thank you both, Bhatia sir and Desarda sir, for enlightening us with the wonderful discussion on the topic. And I would like to share my experience with the Desarda's repair. I was doing a randomized control trial comparing inguinal hernia primary, inguinal hernia repair under Desarda, comparing that with the Lichtenstein, and all the surgeries were done exclusively under local anesthesia. So we had a sample size of 100 and we operated 50 patients in each arm, 50 in Desarda and 50 in Lichtenstein. And after the analysis, we did not find any statistically significant difference between both the arms. In fact, we found one recurrence in each arm, one in Desarda and one in Lichtenstein. And apart from that, other wound complications or chronic groin pain, inguinodynia, and the other wound complications, post-op pain, the time taken to return to work or to resume activities were similar in both the groups. So it was a privilege for me to have been introduced to this method and to be able to learn this and teach teach my juniors this method. And I've always been inspired by Desarda sir's innovation and the thought that would have gone behind innovating a procedure like this. So it is really a very overwhelming opportunity for me to have been able to communicate with you.
Desarda sir, Ankit is much happier not with your technique. Now he is the happiest man meeting you and directly talking to you, because for your technique he was toiling for last 3 years and he has passed it out. Okay, that was great, Ankit. You followed it, and in fact, I was wondering when I reached AIMS, I was wondering how a resident is doing open surgery thesis when everybody is doing laparoscopy and one resident is doing open. That's great. Then I got my mind into it. Come and see what is that Desarda repair. Till then, believe me, I was never interested in your technique or your repair, because I am also, yes, as you told, as I am convinced with my repair, laparoscopic repair, and I am getting fantastic results. So I never bothered for that. But I found, yes, it is such a good technique for a beginner, as Sivacha Mahapatra sir told, for a resident to start off, to get the confidence of getting a technique and repair. And as Ankit himself will also move forward, maybe sometime later he will be changing his mind and he will be surely trying a Audi or a Mercedes. That's, I'm sure also that he will be trying. But Desarda sir by that time has imprinted in his mind that that this before you embark on an Audi, that Alto is a good thing to start off. Sure.
Yeah, in those crowding places, it's better to have Alto rather than BMW.
Great.
To Ankit, you compared both repairs and you found equal results. In such situation, if you get hernia yourself, in which technique would you prefer?
I have already asked that question to him in one of the seminar. The same question
Yes,
I
sir,
had asked him.
I might sound biased, sir. But,
And
yes, I might sound biased, sir, but I would definitely go for a open repair under local anesthesia and a Desarda repair.
In the exact question I once had asked Ankit in one of the seminar when he was explaining Desarda repair. I told Ankit, if unfortunately you get a hernia, would you be like to be operated in my hand with a laparoscopic repair or with somebody who will be doing a Desarda repair? Ankit is such a big fan of yours. He told that, yes, no, sir, I will be liking open Desarda technique. That will be good for me. Then I thought that yes, you have got a Dronacharya and Eklavya. And Ankit is such a big fan. He'll be surely happy to meet his, teacher, whom he was following for last 3 years. Great. Sanat sir, you want to tell something?
I think I'm not audible, na?
You are audible, sir. You are audible. Yeah.
Okay. Thank you. It was a very good talk. Nice discussion with both Dr. Bhatia and Dr. Desarda. I think we have to tailor our patient's need. What type of hernia is, whether bilateral or recurrent or recurrent. And then I think both the procedure we can tailor to our patient.
Absolutely. Ajay Khanna sir, you have any question? Ajay Khanna sir. Professor Ajay Khanna from BHU. Yes, Sivacha sir, you wanted to ask something.
Yes. Professor Manash, I just want to make a comment. Now, sure. Usually my professor at PJ Chandigarh, Professor B.L. Talwar, used to say that if there are many methods for a single problem, then remember that something better is still waiting. And one of you, if he is brilliant or he is very, very creative, he will discover something new. Since there is a debate now whether laparoscopy or the Desarda technique is better, I think there is some method. Now robots have come. Now there's glue may come or something may come. Many robots may come to repair the tissues. We do not know the future. But what I want to say, we cannot ignore the modern and the beginner. We have reached modern stage by starting with the beginning, that I told. But I have seen laparoscopic surgeons who do not know the open cholecystectomy. I am a professor for last 15 years. They operate laparoscopy and then call for open cholecystectomy because they are not aware how to dissect the gallbladder from the liver. The similar is true when you are going for laparoscopy. If you are forgetting the anterior approach, both tap and tape are posterior approach. You reinforce a mesh in the second layer of the posterior wall. Here in the anterior wall, we put a mesh in the anterior wall in Liechtenstein anterior wall. So the inguinal canal is sandwiched between 3 layers anteriorly, 3 layers posteriorly. In anterior approach, we approach the second layer, and posterior approach in laparoscopy, we approach the second layer posteriorly. That is good, but it needs a lot of expertise to go through the posterior wall, whose anatomy is very difficult and a dangerous zone we travel. But the beginning, when we travel through the anterior wall, we know the better anatomy. Desarda is better. But when we advance to a laparoscopic stage, we know that anterior approach is not going to help, as in bilateral, OB is recurrent, re-recurrent. Then laparoscopy, I think, is the best answer.
I think your remark is well taken. Sivacha sir, the last chapter in hernia is yet to be written. I mean, after Desarda sir's technique, some other technique also might come out. Yes, it's always true. Yes, it will come out.
Thank you, Professor Manash, for reinforcing our debating thought.
Yes, it is in fact a pleasure.
I must give you great credit. You are giving justice to All India Institute and Odisha and to all our surgeons, you are the real credit. I am grateful. I am grateful to you.
It's a pleasure on my part, sir, to have all this. It's a much of a social event as well as a learning platform.
Yeah.
So
And I met
we are
Desarda. I have seen Dr. Bhatia before. You know, in Delhi, I was in Delhi and I was in Chandigarh. I'm not very famous, but I know him. But first time I met Desarda, so I am seen my resident doing Desarda technique. And but I do always listen skin. I never do laparoscopic because I'm not, as you know, I'm not doing laparoscopic much. But I enjoy laparoscopic surgery. I know the anatomy because I'm a teacher. But I have heard and seen you. You are a brilliant laparoscopic surgeon, and your result is very good. We are really proud of you. Thank you.
Sir, you are an excellent teacher. You have got tremendous contribution in the field of surgery in Odisha. So we also appreciate your teaching and your experience, which is being shared. Thank you very much, sir, for joining this webinar. So, Dr. Doshi, you have anything to ask?
Yeah, I just wanted to know what is the reason why he doesn't use, Dr. Desarda doesn't use non-absorbable suture materials while suturing is that external oblique epineuritic flap. What is the reservation behind it?
Nothing. There is no reservation. In fact, started with non-absorbable sutures only. But then later on I published an article wherein I have shown that instead of non-absorbable sutures, you can use absorbable sutures also in hernia repair technique. The thing which is never imagined by anybody till today. I was the first to advocate absorbable sutures for hernia repair simply because this is a real tension-free operation.
So, do you use Vicryl or you use chromic catgut?
PDS.
Don't use Vicryl because it is a beaded. It is traumatizing. So better use PDS. PDS number 1 or number 0, whatever you like.
But did you find any advantage except for the change of thread and the cost?
Yes, no foreign body inside the patients, including stitches. Nothing. Your anatomy goes back to normal, as if you had no hernia before.
All right. What about the? You said that the repair. Hello.
Yes. Please go ahead.
Yeah, you said that the repair is dynamic here because of use of the external oblique slip.
Correct.
Yeah, but the dynamics of the hernia, the bulge during cuffing and all is towards the outer side, pushing the abdominal wall forward. Whereas here the oblique will pull laterally and cranially, so superiorly.
Should I show you one very small clip?
Sorry?
Possible? I can show you a very small clip of how this strip is physiologically dynamic in nature to give protection. You see, it's not the abdominal wall. It is the posterior wall of the inguinal canal that protects everybody from abdominal wall inguinal hernias. When this posterior wall becomes weak, then only herniation takes place. And this posterior wall is formed by not the transverse fascia, but the aponeurotic extensions, which I have shown. Actually, operative photographs I have shown. I have hundreds of such photographs, but I have just shown you 2. So, when you replace this posterior wall with aponeurotic structure, it again becomes physiologically dynamic. I think Dr. Doshi, once I get your email ID, I will send you the book and you will find everything over there. If possible, can I show you that physiologically dynamic protection slip?
Please.
I don't know how to just a minute.
You have to share the screen again, sir.
Operation video. Clip of posterior wall. Clip first. Just give me a minute.
Yes. In the meantime, we'll take up some questions. Dr. Madhav, you have anything to say? Dr. Madhav is the professor and head of the Department of Surgical Oncology in AIIMS Bhubaneswar. Though he must not have done hernia for the last 15 years, I'm pretty sure.
Yeah.
But hearing all this discussion, what was your feeling? I mean, what was the enthusiasm that you got? Tomorrow I will be.
No, this is I am very grateful to you that make me a part of this academic meet. I thought I should hear it, and that is, I am very much thankful to both the speakers. They are so good, and I enjoyed the whole debate. Every time when I listen that laparoscopic versus open, I became also very open to learn, and also see, this is the when I have done doing the laparoscopic thing. That's initially I was hesitant in oncology, that is laparoscopy not with the possibility like that way. Once I heard that there is a Lancet publication, that is when they randomized first published that hernia open versus laparoscopy, that I got interested. That time they told me there is no advantage of laparoscopic hernia over the open. The few points were there. But my point is that the surgical innovations came when someone is really interested in giving their thought into that procedures. One should enjoy their procedures, their innovations, and they will give the new things. I think this is the debating to make one superior or inferior. That point I never accepted. But definitely,
this debate, Madhav, was just to create the interest amongst the audience.
That's what I'm telling. That's what I'm telling.
Yes.
That is so good that you have to see a lot of things, and people are always, that's a tendency to go at the newer things.
Absolutely.
But simultaneously,
for 2 minutes.
Yes, Desarda sir, please share yours. Yes, please play your video. It's already shared.
You started the video.
Yeah, okay.
But sound, can you hear
yes.
the sound?
Yeah. No sound is heard. You please go on narrating. Yes.
Because of contraction of the intraoblique muscle and the extraoblique muscle.
No, it is sound is coming. There is a voiceover.
Very good. See, this is
intraoblique muscle, which was not active before, now has become fairly active. It is pulling the stick upwards and laterally along with the extraoblique muscle.
I mean, you wanted to show actually the dynamics of this strip of external oblique aponeurosis.
That is what is the physiologically dynamic protection. Means strip is relaxed when you are at rest without any blow, but it springs into action like a shield to give shielding protection whenever there is a blow. So when you cough, the external oblique muscle, internal oblique muscle, they will contract and convert this relaxed strip into a shield to give better protection. You are already aware that a muscle which is not contracted like this, then there is no blow. I mean, there is no pain, whatever strong blow is there. But if it is relaxed and you make a blow, then it will get damaged. So physiologically dynamic action of the muscle and aponeurotic structures is main important part of the body movements. So accordingly, this posterior wall naturally is physiologically dynamic. And mesh doesn't make it physiologically dynamic, posterior wall. My repair, or our repair, our repair makes this posterior wall physiologically dynamic, just as is seen in normal individuals without any hernia.
I think Dr. Doshi is now convinced with your explanation.
Okay,
could we have Biswa sir, Professor Biswanarayan Mohanty sir is here. He was my teacher when I was an MBBS student and when I was a postgraduate also. Sir, could you throw some comments?
Yeah, namaskar. Thank you, Dr. Bhatia. I have listened to your talk several times, but we are fortunate today we could listen to Dr. Desarda. Dr. Desarda, just one or two questions. Number one is, what was the procedure you were performing earlier, and have you abandoned that procedure after you popularize your technique? That is number one. Number two is, the question which you asked to the Ankit, that if he gets a hernia, what will do? If I ask that if your son gets a hernia and he tells you that, father, please perform a procedure so that I will be cured of this problem and I will not get a hernia recurrence subsequently, then which procedure you will recommend him? That is number 2. And number 3 is a comment that we are so happy that you could change your attitude just to innovate something new. And as an Indian, you are taking this to different corners, and you are, I think you have presented this in several other countries also, conferences held in other countries. And that is, we are so, that is our pride as an Indian, that you took some new innovations and to other countries to popularize a new technique. So there's one comment and 2 questions.
I think Dr. Desarda, before answers your 3 questions, the second question's answer I am giving already, that this will be only Desarda repair, nothing other than that. When his son will ask a question, Dad, what repair you are going to do? You will only repair.
Never know what also Desarda will say.
Sir, what is your answer to 3 questions? I mean, the third was a comment, only 2 questions.
Yeah, Dr. Biswa, I am really glad to meet you and answer your question. First question.
Yeah.
You see, I was never happy with the mesh. When I was resident, my boss used to stitch a piece of terrain. Reliance company was started in India and started manufacturing synthetic cloth in India for the first time in 1970s. But then I was never happy. But then when I started my private practice, then I said, okay, then I tore my one t-shirt, which was prepared from the terrain, and started using the pieces of that in patients. Your mesh was nowhere in the world at that time. And let me tell you, at that time, anybody, for example, Dacron neck hernioplasty, what is that? It is a mesh. But surgeons, senior surgeons like you, thrown it away outright, saying that it's a foreign body. And what is the scenario today? Senior surgeons are supporting mesh. Why? Because no equivalent good pure tissue repair was available. Do not compare my repair with bassini repair and shoulder repair, because you have totally damaged bassini repair and shoulder repair also. Fortunately, nobody could damage my repair since it is published in 2001. 20 years. Because I have a very fixed and simple steps. The recurrence can take place only if there is some defect in the your procedure. For example, do not constrict the ring properly. Keep it little wide open. Then there is a chance of recurrence over there. If you don't take medialmost suture through the medialmost part of the inguinal ligament, the recurrence can occur from there also. We have seen 0.8% recurrences, or you can say 1 or 2% recurrences. The reason was this only, and recurrences were seen in this area only. So the first question, I was never happy with mesh. And then I used bassinis. I never did shoulders. But then bassinis, as you know, it was never a pure bassinis, it was a modified bassini.
Yeah.
So naturally results were not up to the standard. So I started thinking. And then it came to my mind what happened, then I started thinking why hernia takes place. Then started reading anatomy books. Incidentally, I'm gold medalist in anatomy. So I know each corner of the body. So I started reading Nias, right? And so many other people. And then I found that transversalis fascia is fake. Whatever world is talking about transversalis fascia is just papery thin. And no surgeon can ever see transversalis fascia. Whenever spermatic cord is lifted, your transversalis fascia is gone. Because this transversalis fascia is behind the aponeurotic extension layer. And if aponeurotic extension layer is gone, transversalis fascia is absolutely gone. So what is the great idea in talking about double breasting suturing of the transversalis fascia and this thing and that thing? Everything is humbug about transversalis fascia. You want to clarify this? You read those books or read my book, which I am sending it to you. Okay, you will come to know everything with pictures, operative pictures. I am not telling you anything as is said in all the conferences by many teachers. I feel so, or somebody said that, or somebody said nothing. I have proved it with pictures, operative pictures. or pictures given by standard textbooks. So you can see that there is a sea change.
Desarda sir, coming to your comment on transversalis fascia, I think transversalis fascia is an established structure. Dr. Bhatia, you want to respond to this?
I would oppose that.
We'll speak after you read my theory and my book.
My feeling is that, as I told you, that when I was doing the thesis on shoulders repair, and when I shifted from RMR hospital to MAMC back, then Dr. Rana was there, and he said that there is nothing, as Dr. Desarda is telling, that there is nothing called as fascia transversalis. So I used to show him the two bilaminar fascia transversalis, and today, if you see my videos on YouTube also or on other channels, I lay a lot of stress on fascia transversalis.
Absolutely.
On fascia transversalis because it is a pre-peritoneal repair, it is extra-peritoneal repair, it is not extra fascia transversalis repair. There are two lamina of fascia transversalis, and I show in all the workshops that this is the anterior, this is the posterior lamina. You should, and it is cladding the vessels. You should not go into a vascular plane. So believe me, fascia transversalis is a well-formed layer, bilaminar layer. One has to respect it so much, and it is the hallmark.
I agree with you. I agree with you, Dr. Bhatia sir. No, whatever truth is truth.
Truth is what?
Whenever you go through laparoscope, whatever you see is not transversalis fascia, but it is actually patent aponeurotic extension sheet, and attached to it transversalis fascia. Both are fused. Remember, both are fused together to so much extent that it's difficult to separate them from each other.
No.
In fact, falx inguinalis, iliopubic tract, and interfoveal ligament near the internal ring are nothing but the part and parcel of these aponeurotic extensions, which is forming the posterior wall of the inguinal canal. Whatever.
Just a sec. I would suggest that let's have the debate on the anatomy of inguinal region.
I think transversalis fascia is world over is now an established structure given all the importance in the present era, which when we 10 years, a decade back or a decade and a half back, we are not attaching that much of importance. Probably now fascia transversalis is absolutely is taken, but I also agree with Dr. Bhatia because this is one thing which in a laparoscopic repair we give attach so much of importance to that. Anyway, Dr. Doshi, you want to tell something? Yes.
Even in open also.
Yeah.
Open
also. Yeah.
Go ahead. Next one.
Yes. What is the medico-legal implication of a recurrence in case surgery has been done without a mesh?
There is no medical this thing because you are not implanting any foreign body.
No. I am saying that medico-legal implications for a recurrence. If a patient gets recurrence, even after a mesh, sir, just a minute.
Yeah.
If a patient gets recurrence, even after a mesh repair, it is still known. But worldwide, it is understood that a mesh repair done without mesh is going to be having a higher recurrence. Now, if with this technique of Desarda, if we do a surgery not using the mesh, if the patient gets recurrence, what is the stand, medico-legal stand?
See, recurrence, whether it is mesh repair or any other repair, recurrence is already accepted by the world and it is truly accepted.
Not the patient or legal advice argument would be, had you used a mesh, the recurrences chances would have been less.
I'm telling you, it's not because of a repair they are going to sue surgeons who are using mesh. It is because for the mesh complications, other complications. If recurrence is there, he cannot sue because recurrence after hernia repair by any technique is known, an accepted fact. But if mesh gets infected, if because of mesh his testes get atrophic, or mesh migration takes place, or mesh perforates the intestinal canal, so there are so many serious complications, then certainly that patient can go to the court of laws and ask for compensation.
Okay, Prasanna Devta sir, you have anything to ask or give a comment? Devta sir? Professor Prasanna Janta, yes. He is the ex-head of the Department of Surgery in SCB Medical College. When I was there in SCB, sir was there. Yes, sir, please. Sir, you are muted, probably.
Dr. Manas,
Okay.
you know that.
Yes.
You know
Pardon?
you know the time also. No?
Yeah, he is coming. Yeah, he is visible. Yes, please unmute, sir. On the center of your screen below, there is a microphone sign. Just click that, it will be unmuted. Yes, sir.
Manas, I think
yeah, we will call it a day. I think that's fine. Probably he is not getting in. Thank you very much, Professor Desarda, and thank you very much, Dr. Bhatia, for spending this time. And you'll be knowing that at least till the end, also 30 people are still there. I mean, it was so interesting to have this debate, and it was enjoyable to everybody. Thank you very much for attending and accepting my request to join the Surgical Academia platform. Sometime else, we'll have some other kind of a debate. Thank you very much. I really appreciate Desarda sir for your time, and I appreciate Dr. Bhatia for your time and energy. And thank you very much, all the audiences till the last moment for staying back. So thank you, each one of you.
Thank you everybody.
Thank you, sir. Thank you very much.
Manas, as
Yes.
I told you before also, you are doing an excellent job of Tuesday evening show.
Yeah.
Tuesday evening show. And you are doing a wonderful job. And keep keep the flames burning. That is
Thank
more
you very much.
Ultimately, I am not against Dr. Desarda. Dr. Desarda is not against me.
Yeah, absolutely. Absolutely.
If we have such kind of controversies, if we have such kind of discussions, all of us are learners.
Absolutely.
And
Absolutely.
ultimately, the beneficiary will be the patient. So let us continue to benefit the patient, ultimate goal, and carry on learning. Thank you very much. God bless.
Thank you very much. Thank you. Thank you so much. Namaste, everybody. And we'll be meeting next week again. Desarda sir, you also keep joining every Tuesday, 8 p.m. We'll be happy to have you. But yeah, sir, anyway, he is joining every Tuesday. So you please also joining Surgical Academia meetings every Tuesday, 8 p.m. Most welcome. Most welcome.
Please share the recording of the link.
Sure, definitely. I'll do that. I'll do that.
Thank you.
Yeah, sure. Thank you very much. Good night.
And-
Yes, sir. Thank you.
Thank you. Thank you.
Thank you.